report outs this afternoon. Sorry, one from the team in AMS on peritoneal dialysis, a 60-day Kaizen event, and then from Bill Allu, I can see on the screen, on vacancy control and exemption requests. So we'll make a start if we can. I think I'm handing over to, is it Angela Jane and the AMS team? I think I can see them in the little corner there. Yeah, perfect. Thank you.
So thanks everyone. So this is the 60-day report out for the peritoneal dialysis service and the Kaizen event that they had, with the aim of meeting the getting it right first time to increase their service capacity by 20% for having patients come through their home service. Next slide, please. So this is just the project form that we had at the beginning, which is outlining what we were trying to achieve with the PDSAs that we had through the 3-day event. We were able to look at the service, which was currently sitting at around 10% of home patients' capacity. But we were able to map out the value stream map to look at the opportunities for improvement. Next slide, please.
Hello, I'm Angela Hardy. I'm the process owner. Looking at our target progress report, looking at our morale metric, from our baseline, we went from a 2.7. At 30-day report out, we were at 3.2. And interestingly enough, at 60 days, we've got a morale metric of 4. So we've had an increase of 20%, 26% in there. We think a reflection of this increase is because we managed to implement PDSA 1, which is our diaries. We used to have 3 different separate paper diaries, which we've managed to have a PD diary production board, which went live on the 5th of September. The paper diaries have been removed. Everything is now electronic. And I think that's what's reflected in our morale metric there. You can see that we went from 2.7 with the diaries. Obviously, at 30 days, we hadn't implemented it, and we've got our morale metric up to 4. So again, another increase of 26%. Also in the diaries, we looked at defects of things that were altered in the paper diaries. Our baseline metric was 60 defects were measured. At 30 days, obviously, it was the same because we hadn't gone live with this. And then now our defects, at 30 days, our defects were still 43 in the paper diaries, but now we're down to 22 using the production board. So that's just how we implemented PDSA 1. Next slide, please.
So, hi, I'm Carol Milner. I'll be discussing PDSA 2, medication changes. So I think this has been one of the most major successful, the time-saving and sustainability process. So the MDD consists of the clinical lead and a nurse. So initially, the doctor will print out the medicine change, and then the staff member will then have to send that to the ward clerk, who would then have to email it to the GP. So initially, the lead time taken to complete this process on an average for 10 was 100 minutes. And then with the changes, by using electronic system whereby the nurse will electronically produce that prescription straight to a folder where the ward clerk then just emails that to the GP, we had a saving time of 85 minutes reduction. And it also saved on paper as well, because we reduced that by 100%. Defects also reduced by 100% as the electronic script goes straight to the GP, so it's not sat there for a couple of days waiting, for that to go. And it was that successful that we also implemented it to other medicine changes. So, so on an average, doing 2 a day, 10 minutes per change, we've worked out that we're saving 17 minutes reduction time. So it's been very successful. Next slide, please.
No, it's cool.
Sorry,
could you just go back, please? Thank you. Hello, my name's Claire. I'm one of the ward clerks. And this afternoon I'm discussing the PDSA 3, and that's the huddle. So huddles were implemented and sustained straight away after the event. Each morning a leader on point is nominated, and they do a handover to clinical and admin staff of what is happening on the day. At this time, room allocations are given, expectations and the clinic times and jobs are then there forecasted. The huddle time is approximately 5 to 10 minutes each morning, and depending on how the day's plan is going, a further huddle may be implemented in the afternoon. This is boosted morale up by enormously by, well, it's 4 out of 5 now, so it's a 26% increase. The forward planning of the clinics, they're running really smoothly now, and everybody seems to react really well to it. So that's it. Thank you.
Hi, I'm Penny. I'm the other ward clerk on PD. I'll be speaking about the peritonitis packs. Initially, we didn't have these packs made up, so when a patient walked in, it would take a member of staff approximately about 15 minutes to gather all the items that they needed for this. We've now implemented and sustained peritonitis packs. They're done with all the items that are needed, and this saves around about 12 minutes for patient treatment. These are checked on a regular basis. There's a list in the pack to ensure that all staff know what should be in these packs for the peritonitis. Next slide, please.
Our key learning, what we feel went well, was that we managed to implement 3 PDSAs within the first 30 days. We ran another PDSA cycle to make them changes with the other medication changes. And then now at 90 days, 60 days, we've implemented a further PDSA, which was the electronic diaries, the PD production board. What I think is really good is improvement to staff morale, and staff commented on there saying that they now feel empowered, which is really, really great to hear. The barriers that we faced was the IT access to the electronic diaries. That's why we couldn't get that one up and running at 30 days. The computers didn't have MS Teams. We also needed to learn how to use Teams and how to log on. We're using the diaries well. We've got teething troubles, but the more we use them, the more it'll settle. What, if anything, we would do differently is that when we got the production board going, we loaded it with too many buckets. We got a bit carried away. So we reflected and changed it, and we took some of the things out. Moving forward, we might add more buckets as we get more confident using the system. Next slide, please.
So my name's Jeanette Denning, and I'm just going to conclude this with our next steps. So next steps are level loading of the clinics and review of the skill mix and the necessary PAS work that goes along with this. Steps that we've taken so far, so we've implemented some flow charts to ensure that the whole team know exactly what procedures are required for different aspects of the appointments, and to ensure that we're all working the same. So we've already got flow charts for established patients, pre-PD patients, and making the appointments for 7-week follow-up after PD catheter insertions. So what's our next steps? So this would be PDSA 4, and we're looking at appointments and home visits. So when we say appointments, that's like clinic visits. The overall aim is to have patients coming in to the unit a bit less, so that we can do home visits and keep the patients at home, which, as I'm sure most patients would agree, that's where they want to be. We'd be looking at lead time, so to complete home visits. So we're looking at skill mix and probably sending out two staff to visit patients, so it will make the visits quicker. which we're hoping then we will be able to see more patients throughout the day and increase the establishment that we have. You can see from 2 patients to 6 in a day. Patient feedback, customer feedback, we would be looking at in the future formalising something so that we can actually see if this is what the patients want. And then reducing the number of face-to-face hospital visits, like I say, bringing patients in less. With that, it hopefully will be a bit more organised. It will allow to free up staff to sort out your skill mix to do other things. Hopefully we would have less transport issues and everything else that goes with that if we're doing more home visits rather than bringing patients in. Established PD patients, so less time spent in the face-to-face appointment clinics, so 3 hours, getting that down to 45 minutes. Other things that looking at for home visits is patients bring adequests in, which in a nutshell is some of them having to bring in large quantities of fluid, urine canisters, that kind of thing, and transport them in. But if we do those as home visits, then it means that we bypass that for the patients, making that easier for them. And a reduction in nurses carrying equipment, which obviously has health and safety issues. So we're looking at or are implementing not carrying the equipment with us. So there's things like BCMs for patients and glow boxes, hand wash techniques. So they're quite cumbersome pieces of equipment to take out. So we're changing the way we do those, and on the odd clinic appointments that the patients come in for, they will be done in-house. So we don't have the equipment to carry out. So I think that concludes that.
Yeah.
Yeah.
Okay, thank you. We'll move on to questions at the end once we've heard from Bilal, if that's okay. But that was fantastic. And sorry, I think I forgot to introduce myself. I'm Mike Harvey. I'm Director of Transformation here at LTHC, so apologies for that. Bilal, over to you.
Thanks, Mike. So just before I kick off, I'm just going to give you some context to what the exemption request process is. So the ICB asked the trust to introduce vacancy control measures around 2 years ago. As part of those vacancy control measures, we have this exemption request process. So if you have a vacancy in your team and you wish to recruit, you may be advised that you have to wait 13 weeks. If you feel you can't wait 13 weeks, you will apply for an exemption request. And this is where we come in. Next slide, please. So the problem we had was we're getting 30 exemption requests a week. We've had maybe 1,200 since the start of the process. Mistakes were being made in processing, leading to delays for CSUs in their recruitment. And as you can see the pictures, we had a lot of people that were not very happy, and I could feel some virtual eyes looking at us this way. So we knew we had to do something to change this and reduce the number or achieve 0 defects, mistakes being made. And the work we were doing in this part of this project links to the 7 Season team and finance. Next slide, please. So the aim was to mistake-proof the 13-week exemption request process to achieve 0 defects. At the moment, before we did this improvement work, it was basically one of the team looking at all the panels that have been held that week, trying to filter through dates, include them into a paper that goes to the execs, and the exec would then have oversight, and we would then feed back to the CSUs. The problem is we wouldn't know we'd missed their request until a CSU would send a chaser email. So we didn't know what we didn't know until somebody told us we'd made a mistake, and we felt as a team that wasn't good enough. We had to improve our process. Next slide, please. So what we did, we had team engagement sessions, we did a process map, and we introduced some visual controls. Next slide. This is the process map that we did. So this was really beneficial because we thought we knew the process, but when you actually map it out, put it on the wall for yourself, for you to see, you realize, this process is more complicated than we thought it was. So as a visual person, it was good for me to see it on there and see, okay, this is how it works. Where are the mistakes? And if you can see at the top, there's a green box that says TERG exec paper. That one little box, if we missed a request in that paper to the exec team, the exec could make a decision on it, and your request couldn't be processed. And that was the major problem missing out in that paper. Okay, so if you go to the next slide. So what we did was we introduced some visual controls, which made life so much easier. So I know if it's green, that means it's just been added to the tracker. If it's blue, it's been to the tier 2 panel. They've made a recommendation on it. If it's orange, it's been in the exec paper. It's gone to execs. They've made their decision on it. And once it's speckled out, it means that we've fed back to the CSU. We've got a date when we fed back, and we know who fed back, just to provide that assurance. So now, when whoever's writing that paper, we no longer have to mess about with dates and filter. All we do is we just look at the ones that are in blue. So I just filter for blue. That gives me everything I know, everything I need to add into my paper to the execs. Next slide, please. Just by doing those visual controls, we've achieved 0 defects. And I suppose it's a crude measure, but I'm measuring by the number of chasers. We don't get any emails telling us we've missed it. So it's very crude, but we haven't received any. So we're confident we've achieved 0 defects. The other thing we've done is we added a column so I manage one panel. In that panel, there's 5 CSUs that make up that one group. I do it on a weekly basis. I forget which CSUs I'm looking at this week, next week. So by adding a group, our team was able to create little data points where all I do now is I click on the group and the CSUs are already in that group, which has saved my time in preparing for a panel by 2 minutes and 22 seconds. And it helps us increase our assurance by including that last bit. So when the request has been processed, if somebody does send a chaser email up, I know who fed back to the CSU and I know when they fed back to CSU. So it's easy for people to look through their emails. Next slide, please. What went well? Engagement, team engagement. The team were really engaged because we knew we had to do better. We knew the delays were creating frustration for CSUs. The process map, it really helped us understand the complexity of the process and understand where the points are that could go wrong and where to work. And implementing the change within our team, everybody was open to it. We knew what we had to do and why we were doing that change. Next slide, please. So what I do differently, I think biggest thing for us was using more metrics. We used some, but we should have used more, such as customer feedback. And the image tells you, there are friendly customers out there as well. So that's one thing we looked at. We will do next time. Next slide, please. We have done another PDSA on the work we did. And as you can see, we've crossed stuff out. We're looking at different parts of the process to how we can improve it better. One thing we did that we didn't realize would be such a huge impact on the work we do is we added a column which shows when that request was actually added to our tracker. So if we know when it was added and we know when the feedback was given, we can time the process to see how long it takes. So we know when the panels happen each week. So in a perfect world, it would be a week to 10 days. So now we know how fast we are processing these requests. So that's been really huge for us to have that data. Next slide, please. That's it. That's me done.
Thanks, Bilal. Really appreciate that and really great work as well. Can I just check before, I've got a couple of comments, but are there any questions, any observations on both of those presentations? Yeah, Katie.
Thanks. Thanks both teams. Well, Bilal and the team PD team. Some great work going on. Good to see the improvement methodology being used. Bilal, I thought it was really great that just something small like adding a column isn't big transformational thing, but it had a big impact. And I think we sometimes underestimate how those small things are actually improvement, and they have quite a big impact. So I thought it was really good, and I thought you'd use quite good data actually. It's difficult in improvement to find data, and I think you did really well at that. So yeah, thanks for that. And PD team, I have a question about going paperless, the electronic diaries. That's quite difficult to get teams who are using sort of paper use of things. It's quite a difficult change to make, and I just wondered how you guys got on with that. Have you got any tips for helping other people transfer over into using more digital?
We just picked it and went with it. We had to take all the information that was in the diaries, make sure it was all loaded on. So we sat and inputted all the information that was in the paper diaries onto the electronic diaries, and then we hid the diaries.
Love it. Great.
So,
and it worked.
I think something else to add to that, as I think as a team, it was something that we all 100% wanted to do. And I think if you've got that within the team, then it's going to work, because you're going to make it work.
Yeah.
Great. Thank you.
Thank you. Dolph?
Hi, nice to see the team again. I was involved in the original RPIW, and it's great to see the progress that's been made. I just have a question about home PD. Are you looking at all at increasing the number of patients that can do PD at home rather than going to clinic?
Yeah, that's his overall aim. But ironing out all these initial things first is then hopefully the improvements that we've made now, we can focus on increasing our numbers at home. Yeah.
Excellent. Thank you.
Thanks, Dolph. That was actually a point I was going to just come on to, I suppose, was, you know, certainly for the PD team, I can see the approach that you've taken and that real emphasis on teamwork and, you know, the benefits that across both clinical, nursing, admin, in terms of how the organisation of the clinics work, but also, you know, the end, I suppose that end benefit that you will be bringing to patients, you know, and I would imagine anything that increases the likelihood that renal patients don't have to come in as frequently as they currently do is going to be of benefit to you. And I wondered, you know, is there more that we can do to engage with our patients to get their sense of, you know, how far they would like us to kind of take this approach, really? Because I think you're right from what you were saying, you know, there's a little bit of getting your house in order first before you're able to then kind of expand out. So it would be an area for the PD team, I think, you know, looking at, you know, engaging with patients. I'm not saying you're not already doing this, but I'd be interested to know how far you might think you could push that to, you know, to the benefit of patients not having to come in as often. Just wondered what you thought about that.
So my background is within home hemo. So within home hemo, we started by visiting all the satellite units. So we've got established patients that are on hemodialysis, and it's just making sure that they're aware that there's also different modalities. There's PD. So the home hemo team actually go out and go around all the satellite units to have contact with the dialysis population, and in that conversation they talk about PD, and they make sure people are aware that PD is an option. We're working with low clearance work with us so that they know what options are available for patients to dialyse at home, both PD and HD. We do want to grow the numbers, but it's definitely getting house in order first. I think all these improvements have proved that we've got more time available now that things are running smoother and clearer, and that we want to go out there and just make sure people do choose PD.
Yeah, no, that's fantastic. I think, you know, hanging on to those two things, which is the benefits to you as the team and then the benefits for patients, I think is really crucial, isn't it, in kind of sustaining this over the longer term. So it's brilliant. Just keep going with it because it's fantastic work. Bilal, just on the vacancy control thing, I just wondered again, it was a question about, because you mentioned it about customer feedback, you know, and I hear frustrations with the vacancy control thing from time to time and the length of time it takes sometimes to get a decision made. And you know, Katie's point around the, you know, the word I'd written down was transparency. You know, the being as transparent as you possibly can be about the process is really important, particularly in the situation that you've been dealing with. And I wonder whether there's opportunities to, you know, to expand that further and be really open with the data. I don't know quite how much you share of your tracker, for example, with the CSU teams, but, you know, being able to nip things in the bud and make sure that people are aware that things are going through the process and that they are, you know, certain things will take time and there's exemptions within that process, but you are following a logical sequence, I think is important to people feeling like, you know, they're not being kind of sidelined in all of that.
No, this is a really good question. So it's hard to share the tracker because there's a live tracker.
Yeah.
And we've had people in there and changing things, which has caused issues down the line. So it's restricted to our team. We have recently developed with HR, we've developed a whole new guidance and standard work that has gone out. It's just gone through TERG, so it'll be coming out soon. So we've tried to improve the comms and explain the actual process these follows. We know the service that we had to improve the service. It wasn't good enough, and it was for our own transparency reasons to make sure that if somebody was chasing something, we knew where it was. But it's a work in progress. Things happen, you know, and I'm sure people might not know that a tier 2, so there's a tier 1 level, which is your own internal vacancy recruitment panel. We're looking at the tier 2 bit, which is the members of those panels are very senior. So you got medical, nursing, HR, finance, and because of the pressures in the trusts, sometimes getting a panel that's quora each week can be tricky. Yeah. So there's little things that are out of our control that we're trying to work on. But you're right, you know, that's something that we'll work on with colleagues from across the to see what we can do to be more transparent.
Yeah, that's fantastic. Okay. Unless there are any other questions, I think that's the end of Report Out for this Friday. Have a good weekend, everybody, and we'll see you all next week. I think is the next one. Thank you very much. See you soon.
See ya.
Thank you.
Thank you.
Thank you.